Alright, so today we're going to be talking about advanced airway management. So basically, this is going to be emergency situations where there's a compromise to the airway or someone's in respiratory distress. And so we have ways to control the airway and make sure that air is able to pass, and then also way to artificially ventilate. So I'll have a few videos in here as well, and I will put links to those videos um, in the PowerPoint as well, so you can watch those, but we'll also watch them together. So let's get started with our first video here, explaining the basic anatomy and physiology of the respiratory system.
In this video, we will study about the respiratory system. The human respiratory system is one of the most vital organ systems of the body. We breathe about 16,000 to 24,000 times per day, which exchanges about 11,000 liters of air with the atmosphere. In this process, the oxygen of the atmospheric air is delivered to the human body, which is then utilized by all the tissues, and the carbon dioxide which is produced by the human body is exported to the lungs and then exchanged with the atmospheric air. In this video, we will first talk about the brief anatomy and physiology of the human respiratory system. Then we will discuss how the gas transport to the alveoli occurs. We will talk about how the human respiratory system works together with the circulatory system. And then we will talk about how the gas exchange happens in the alveoli. So first, coming to the anatomy and physiology of the human respiratory system. The vocal cords present in the larynx divide the respiratory tract into the upper respiratory tract and the lower respiratory tract. The upper respiratory tract contains structures like the nasal cavity, the pharynx, and the part of the larynx above the vocal cords. The lower respiratory tract starts with the part of the larynx below the vocal folds, trachea, bronchi, bronchioles, as well as the alveoli. So let's first talk about the brief anatomy of the nose and the nasal cavity. Now if we take a look at this diagram in a bit detail, we can see that the nasal cavity is made up of a roof, which is in turn made up of the bones forming the base of the skull. It also consists of a floor which is made up of the palatine bones. The main job of the nose and the nasal cavity in the respiratory tract is the filtration of air. This is made possible by small, minute, hair-like structures present in the nasal cavity called cilia. The filtration of air is also facilitated by the mucus which is secreted by the nasal walls. This traps dust, pollens, as well as other pollutants present in the atmospheric air. The other job that the nasal cavity performs is warming and humidification of the air, which prevents the dryness in the respiratory membranes. Oral cavity also serves as a secondary opening for the respiratory tract. The downside of this is that there is no filtration, no humidification, and no temperature regulation through the oral cavity. But there is a plus side also, which is that the oral cavity has a wider opening, so it facilitates greater intake of air during exercise. So up till now we have studied the air that we inhale passes through our nasal cavity or the oral cavity into the pharynx. So coming to the next important structure in the human respiratory tract, which is the pharynx. Pharynx is basically a muscular tube which lies behind the nose, the mouth, as well as the larynx, and it connects the oral and the nasal cavity to the larynx as well as the esophagus. Now the part in the blue you see is the part which is called the nasopharynx. This is the part which lies behind the nasal cavity. The second part of the pharynx is called the oropharynx, which is the part in the green which lies behind the oral cavity. And the third is called the laryngopharynx, which lies behind the larynx. So the air that we inhale through our nose or through our oral cavity passes back into the pharynx. When the air reaches the pharynx, it has two important structures where it can go forward. The first is the trachea, which lies in the front, and second is the esophagus, which lies at the back. Normally the air enters into the trachea because esophagus at normal conditions is a collapsed structure. One important structure to note here is the epiglottis. The epiglottis is basically a cartilaginous structure which closes the entry of the trachea and prevents the entry of food. It is an elastic cartilage which closes the laryngeal inlet and prevents entry of food into the trachea and further the lungs. The next important structure in the respiratory tract is the larynx. The larynx is located right here, and it is also known as the voice box as well as the Adam's apple. The larynx is made up of many cartilages, and the larynx contains the vocal cords. The main functions of the larynx in the human respiratory system is that it connects the pharynx to the trachea, and the second important structure is the production of sound or speech. The next important structure is the trachea. So the trachea is basically a tube-like structure which connects the larynx to the bronchi, and the bronchi in turn connect to the lungs. If we take a closer look at the section of the trachea, we can see that the trachea is basically made up of 20 C-shaped cartilages from above to below. These cartilages basically prevent the collapse of the trachea because there is a negative pressure in trachea as well as the lungs during inhalation. If you see closely, these tracheal rings are basically C-shaped. These are not completely circular because esophagus lies behind the trachea, and if these rings were circular, they would have compressed the esophagus during swallowing, and this could have led to choking. The trachea then divides into the primary bronchi. Now this is called the primary bronchi because it is the first division of the trachea. The primary bronchi then divides into secondary bronchioles, and then the secondary bronchioles divide into the tertiary bronchioles. Now what happens next is that these tertiary bronchioles again divide for about 20 divisions to form the conducting bronchioles. So you can see the tertiary bronchioles divide many times to form very small sac-like structures. The tertiary bronchioles lead into the conducting bronchioles. The conducting bronchioles then form a 4 to 5 division series of respiratory bronchioles. These respiratory bronchioles are in turn connected to the alveoli. The alveoli are sac-like structures in which the actual gas exchange happens. The conducting bronchioles are called conducting bronchioles because no gas exchange happens in them since they have large or thick walls. But respiratory bronchioles have very thin walls and some amount of gas exchange can happen in these respiratory bronchioles. But majority of the gas exchange happens in the alveoli because of their close proximity to the blood vessels. The division of the bronchioles to such an extent increases the effective surface area of the lungs. So the air that we inhale finally reaches into the alveoli. Now let's look at this diagram to understand how the respiratory system of our body works in conjunction with the circulatory system to provide gas exchange. In this diagram, you can see the lungs, the heart as well as the circulation pool of the body showing the deoxygenated blood in blue color as well as the oxygenated blood in the pink color. The heart receives all the deoxygenated blood from the body through the superior as well as the inferior vena cava. This blood has a low concentration of oxygen and this is then pumped to the lungs through the pulmonary arteries. In the lungs, this deoxygenated blood is subjected to gas exchange, which converts it into oxygenated blood, which is pumped back to the heart. The heart then pumps this oxygenated blood to the body, which utilizes the oxygen present in this blood. And again, this blood is converted into deoxygenated blood, which is pumped back to the heart. The heart pumps all the deoxygenated blood to the lungs through two main arteries, the right and the left pulmonary artery. Just as we saw with the previous branching pattern, that a single bronchus almost divides 20 to 25 times before the formation of alveoli. The similar phenomena happens with the large blood vessels that enter into the lungs. These blood vessels also divide several times, which leads to formation of small capillaries that are in extremely close contact with the alveoli. Due to this, the cardiac output that comes in the large vessels divides into many small streams of blood. This leads to exposure of the 5 liters of blood coming through the heart to almost 250 to 300 million alveoli per minute, Due to this, a rapid gaseous exchange happens between the alveolar air and the blood that is exposed to the alveoli. Now let's try to understand how the actual gas transport happens inside a single alveoli. So the air that we inhale passes through our respiratory tract deep into our body into a bunch of structures called alveoli. Well, this is important to create a very less distance between the alveolar air and the blood. Now to understand this, take a closer look at this section of an alveoli which are attached to the end of a respiratory bronchiole. You can see that a bunch of alveoli are surrounded closely by blood vessels. If we take a single alveoli out of this bunch and magnify it under microscope, we can see that the alveoli is completely surrounded by a single capillary, but in reality they are surrounded by multiple capillaries to have very close contact with the blood. In these capillaries, the deoxygenated blood enters from one side, it exchanges the gases with the alveolar air, and finally oxygenated blood is released from the other side. If we take a closer look at the junction between the alveoli and the capillary wall, you can see that the green side represents the space inside the alveoli. The cells in the sky blue represent the alveolar epithelium. On the other side, we have the blood vessels which contain the RBCs, and the wall of the blood vessel is the endothelium. In between them is the basement membrane which separates these two cell layers. So you can see clearly that the air that we inhale in the alveoli is in very close proximity, which is approximately few micrometers from the blood vessel. Here comes the role of difference in the concentration of gases on either side. Most of you know that the diffusion occurs due to the difference in concentration of a substance on either side. So if we take a look at the concentration difference of the alveolar air and the blood of carbon dioxide and oxygen, we can see that the alveolar air has a low concentration of carbon dioxide as compared to the blood, which has a higher concentration, whereas opposite of that is true in case of oxygen, where high concentration of oxygen is present in alveolar air as compared to low concentration of oxygen in the blood. Due to this, the high concentration of carbon dioxide is exchanged with the alveolar air and the carbon dioxide is released outside in the atmosphere, whereas the fresh oxygen that is coming through the alveolar air is transported to the blood and the blood is made oxygenated. So the blood coming on one side of the capillary, which is a deoxygenated blood, is converted into oxygenated blood on the other side. This oxygenated blood is then sent to the heart, and the heart then pumps this oxygenated blood to whole of the body, which is then utilized. So this was a brief description of the human respiratory system. I hope you found this video helpful. Make sure to help our channel by subscribing to our YouTube channel, and also make sure to like our page for all the flashcards, mnemonics and upcoming stuff. Thank you so much for.
So the point there is to give you a basic understanding of how this all works. And so you have to think of a couple of different things in there. First, think of the passage of air through the respiratory tract and all of the different places where any sort of swelling or increase in resistance to the air by decreasing the space available could lead to a decrease in overall airflow, thereby affecting the ability for that gas exchange to occur. Second, we also need effective gas exchange. And so we'll be able to measure that effective gas exchange by measuring the oxygen saturation levels of the blood. So when we look again at the anatomy here and the oral phalanx and the nasal phalanx, what we're really looking at in this point here, right, in the pharynx area, is we have to pay close attention to the fact that we have the nasal and oral pharynx. But when we get down here to the epiglottis, that's where we're going to get the possibility of air to diverge into the esophagus. And so once we get past this area here, either from the nasopharynx or the oral pharynx, and into the trachea, at that point usually we've established a fairly good airway overall, or at least what we can be doing. So you'll see when we talk about our advanced airway aspects, what we're going to be looking at is trying to create an artificial airflow tube around which or through which air can get down into the larynx and then eventually into the trachea. So just getting a little bit closer in there, you can now see the pharynx into the larynx, the trachea, down to the bronchii and the bronchioles, and then finally down to the alveoli. Okay. When we're talking about respiration, the diaphragm is by far the most important muscle when it comes to respiration, and its job is to create the negative pressure through which inspiration occurs. And so when the muscle contracts, it flattens out the rib or the air volume in the lungs by increasing the air space and decreasing the abdominal space. That's why you can see your belly push out when you breathe in deeply. What's actually occurring is that diaphragm, which is up like this to begin with, flattens out and is actually pushing your intestines out. So the air is not going down into your belly. What's really occurring is you're flattening out, pushing, and what you see coming out into your belly is actually your intestines. The air obviously stays up in the lungs, but as I can contract that muscle and it flattens out, it increases the space above for the air and decreases the space for the intestines. And so when you do that, when you increase that space, you increase the volume and thereby decrease the pressure. And so air is going to rush in through that decrease. So it's really like you're sucking in air. And then when you relax, you get the opposite, and the air moves out as the pressure increases. So we give that the term of inhalation. It's negative pressure breathing. That becomes important because what we will end up doing in situations where they're unable to breathe for themselves, we'll do positive pressure breathing, in which case we're blowing air into the lungs opposed to letting air come into the lungs. So like I said, the diaphragm contracts downward, increasing the volume of the chest cavity. The external intercostal muscles move ribs upward and outward, increasing volume. And this is for more labored breathing when you're working harder at that. That allows the air to come in and transfer the air to the capillaries. And as we saw, we get that gas exchange. Now, exhalation is the process of removing the air that is in the lungs, right? After you inhale, you have that air in there, and that's going to exchange, and so it's going to have relatively less oxygen and relatively more carbon dioxide. As we'll see a little bit later, it's not like that's 100% exchange. All right, we have carbon dioxide that goes in, but it's not like all of the oxygen goes to the capillaries and all of the carbon dioxide leaves. It's simply a diffusion aspect. And so we have exhalation, which is just that passive process of blowing out. Normal exhalation is passive, okay? And as the diaphragm and those intercostals relax, the chest cavity moves upward. That increases the pressure in the chest and forces the air out. We can also have a more active exhalation, right? When you're like coughing, right? And you're using the muscles of the intercostals to squeeze the rib cage in the lung cavity, thereby forcing air out. Okay? And so that's how it works, but how it works is not nearly as important as if it is working or not. So we're going to spend some time talking about adequate versus inadequate breathing. And basically this is very simple. Adequate breathing is real breathing, right? We have enough airflow to allow for that gas exchange to occur and thereby sustain life. So that's adequate breathing. Inadequate breathing, right, is anything that cannot sustain life. And so this becomes rather important because we talk about breathing as if like it's breathing or no breathing. And in reality, there's a lot more steps between completely not breathing and normal adequate breathing. And so for the purposes of emergencies, we're just going to draw the line at adequate versus inadequate breathing. And so when we go to assess this, this is going to be our primary assessment. So if we go back now to thinking about our primary assessment from first aid, CPR sort of stuff, when we arrive on the scene, we check for the scene safety, we do our BSI. The next thing we're going to do is check for circulation, our airway, and breathing. Okay, and so this is that establishing the airway, looking for that breathing for the chest to rise and fall, listen and feel for that air exchange, determine that rate, rhythm, and quality that we talked about previously when we were doing assessment. So let's talk then about signs and symptoms of inadequate breathing.
At the Mesa Fire Station, dinner was being prepared by the shift on duty, led by Captain Jim Baird.
We'd just come back from call about 15 minutes before. Had been getting a lot of kids in the park coming and ringing our buzzers.
Hey, let's go, we got something.
He's not breathing.
The next thing I remember is the fireman grabbing him and pulling him out of the car to one side.
What's wrong with him?
It's asthma. It's asthma.
They just brought him out of the car and laid him right down there on the concrete. He was not breathing. There was nothing.
Dispatch, ambulance code 3. Helicopter on standby.
I copy.
Hello, I'm Sean. EMS frequently responds for assistance due to difficulty breathing. This video will provide you with what signs and symptoms to look for in a respiratory emergency. Knowing the signs and symptoms of a respiratory emergency will allow you to aggressively treat your patient and make potentially life-saving interventions. EMTs and paramedics are the first lifeline in the EMS system, and as such we have the greatest opportunity to provide direct interventions and treatment that could potentially save a patient's life. Remember, the primary assessment is always airway, breathing, and circulation. If you have an unstable airway or an inadequate breathing, these must be addressed before any other interventions. Often an emergency involving an unstable airway or inadequate breathing will be aggressive and rapid treatment by EMS. This is our lifeline. This is where we, as pre-hospital providers, have tremendous value and impact in saving lives. So, let's now take a look at some examples of signs and symptoms that you may see in a patient in respiratory distress. Obviously, anyone who has a hard time breathing is going to be anxious. That's one of your first cues that there's something going on. Okay, but what else is going on with the patient? Well, any patient who has a severe respiratory emergency is going to have pale, cool, and sweaty skin. 92% or less, we're going to be delivering oxygen. So you have to have oxygen saturation levels in order to deliver oxygen. Along with using the oxygen saturation machine, use of your stethoscope as a first responder is key. Adventitious breath sounds are a sign of respiratory distress. Let's listen to some of those.
Two basic types of adventitious or added breath sounds are the discontinuous sounds, crackles, and the continuous sounds, wheezes and rhonchi. Crackles are intermittent, non-musical, and brief, like dots in time. Fine crackles are soft, high-pitched, and very brief. Coarse crackles are louder, lower-pitched, and longer. Compared to crackles, Wheezes and rhonchi last much longer and sound more musical. Wheezes are relatively high-pitched and have a hissing or shrill quality. Rhonchi have a lower-pitched snoring quality.
EMTs and paramedics have to know how to listen to lung sounds with your stethoscope, and you have to be able to determine wet sounds versus dry lung sounds and what may be going on in the different indicators that happen as such. Along with noting the sounds that are hearing, you also want to note if you hear diminished lung sounds when you compare them. If you hear diminished lung sounds when one lung compares to the other, it could be a pneumothorax, it could be an obstruction, it could be multiple things. So you definitely want to listen to the lung sounds and listen to them good. Now let's look at some more external signs and symptoms of respiratory distress, beginning with stridor. Stridor is a sound that's unmistakable. Let's take a look at a video.
Now he don't.
That whistling sound that you heard when the baby was taking a breath, that's an actual airway obstruction due to swelling of the airway. It's called croup. Okay, the disease is called croup, and if you hear that, you need to get that patient to a hospital. Also, with our pediatric patients, we're looking for substernal and suprasternal retractions. It's real easy to see in children. They're trying so hard to breathe, it's called accessory muscle use, and you can actually see the skin retract between the ribs and up by the patient's throat. This happens in pediatrics, but you can also see this in adults. So let's take a look at that and see what it looks like.
He's probably going to be going this guy's room.
Most likely, yeah.
Pretty clearly visible, as you can see. Other things that are real easy signs and symptoms for respiratory distress. How is the patient talking? Are they speaking in full sentences, or they may be speaking 1 to 2 words before they can actually have to take a breath? Okay, so if they're truly in respiratory distress, they're not going to be able to talk. You want to note how many words they can get out before they can actually complete their sentence. It may be 1-word sentences, 2-word sentences. Note that on your PCR, and also note if it improves on the reassessment. Things to look for in your patient with long-term chronic obstructive pulmonary diseases, an emphysema or barrel chest. In a normal adult chest, you really have as you can see in this graphic here, the ratio is pretty even. Okay, as the patient's accessory muscle grows and as they struggle to breathe, their chest gets out and is barrel chested. You also see pursed lip breathing. Those patients with long-term respiratory illnesses and disease. Okay, so you can see this patient here, she's pursing her lips to try and force that breath in, and you also note that her nostrils are flaring. Okay, nostril flare is great for both adults and pediatric because you can see that very markedly in little kids. Okay, also tripod position. You can see that as soon as you enter the door. What that is the patient's leaning forward and they're pushing down on their hands. Okay, sitting upright. They're trying to relieve pressure on that diaphragm and allow more room for the diaphragm to expand and contract, and also allow for more use of the patient's accessory muscles. It's both in adults and pediatrics. So now you know what to look for. Let's go back to our original video and see what the outcome was on that young boy with a severe asthma attack.
The boy was as close to death as anyone I have ever seen without being dead.
I put my hand on his wrist initially. I couldn't find a pulse. Then I moved up to his neck.
Okay, we got a really weak pulse. It's about 40. It's maybe 40.
When you find a child in this condition, it's like starting a race 10 yards behind everybody else. You got to make up all that distance in 1 extra yard to win.
Relax, hang in there, Michael.
You hear the firemen say, he's not breathing. If he can't start breathing pretty soon, we're going to stick a tube down his, lungs. And all I could just think is, please don't take him.
What kind of medication is it that he's using?
Benylin. It's on Benylin.
I pulled out a drug called epinephrine, which is a very powerful stimulant for the heart. It also causes the lungs to dilate.
Bagging him. Good air exchange. Fair. Not much air movement at all.
it's happened before where I've done all the right things and it didn't work.
Yep, he's on board.
I was just hoping, man, I hope this works.
Okay, time now. Okay. Hey, do one more. Okay, we got some respiratory effort. Come around, man.
You could see his chest start to rise again, and it was the best feeling ever to see that, because you knew there was a chance.
Michael, you're doing great, buddy. You are doing great, man.
They started giving him treatments of all different kinds. Got an IV in him, and Michael started becoming coherent again.
Medication right now. No, I already poked you once. I'm going to poke you again.
I was a happy man.
At that point, when I started thinking about my daughters and their asthma, and that's when your own emotions kick in. The mom and dad were not the mom and dad to me. It was more like I was in their situation looking at my daughter in that helicopter flying away.
Strong work, Mesa Fire Department. As you can see, that crew knew and recognized that there was a respiratory distress and a severe emergency, and they recognized there was an asthma attack. They gave the kid epinephrine and they saved that kid's life. Okay, so I hope you learned something from this video. I hope you picked up a few signs and symptoms to add to your slideshow so you can recognize and treat in the very early stages an emergency involving airway or breathing. Okay,
So when we're looking at this, we'll go through some of the signs and symptoms as well. But when you look at this, it really doesn't matter per se all of the differences. What matters is, do you recognize that there is inadequate breathing that's occurring? And at that point, we're going to treat most inadequate breathing the same. We're going to maintain the airway, administer any medications that we've been authorized to do, and then if need be, add positive pressure ventilation. So we'll take a look now at what these positive pressure ventilation sort of things start to look like here. But before that, let's look at this idea of airway disease versus alveolar disease, because even though we're primarily going to be looking at airway disease, it is quite possible that you'll have this alveolar disease as well. So we'll take a look at this here before.
Now that we've covered the basics, it's time to go a step further in developing skills to refine our ventilator settings for the patient. Now, before we do, we need to determine which general lung disease category the patient falls under once they are mechanically ventilated: airway disease or alveolar disease. So let's look at several characteristics of these two general lung disease categories, and we'll begin by observing some basic characteristics of airway disease, and then we'll compare that with the characteristics of alveolar disease. Understanding these characteristics will lay the foundation for how to refine our initial ventilator settings. So first, the airway disease patient. Now, when we refer to airway disease, we're simply referring to the physical airways that carry volume in and out of the lungs. Normal airways should be patent and allowing for adequate flow of volume. The inside of a normal airway should look something like this: wide open and patent. But in a patient with airway disease, the inside opening of the airway becomes narrow. This can be caused by inflammation inside the airway, which reduces the opening diameter, or mucus in the airway, which also reduces the opening diameter of the airway, or even if the patient has asthma, where the smooth muscles that wrap around the physical airways can constrict and squeeze the airway opening so that it also becomes more narrow. Now, the general description used to classify these types of airway diseases is obstruction. That's because the opening of the airway is obstructed or narrow due to inflammation or mucus or smooth muscle airway bronchoconstriction. So what's the main challenge with these types of patients? Well, with these patients, getting volume into the lungs isn't necessarily the main challenge. A patient with an obstructed airway disease should still be able to inhale an adequate amount of volume. Now think about that. If you switched from inhaling through a large bore straw to a narrow bore straw, You would still be able to inhale the same amount of volume, but you wouldn't be able to inhale as fast. So it's important to note that the main issue isn't necessarily getting adequate volume in. The main issue is getting the volume out of the lungs. So watch. Try this experiment. Go ahead and mimic exhaling through an obstructed airway. Let's obstruct our mouth by pursing our lips. Now, go ahead and take a deep breath in and then exhale. You should notice that getting the volume in is not that difficult. However, exhaling all the volume takes a lot of time. Now, depending on how much you purse your lips, you can actually exhale for up to 20 seconds. So airway disease patients will actually be at risk of air trapping. This is where accumulated volume over a long period of time actually stays trapped in the lung. This also means that CO2 is not properly being ventilated out, since some of the volume which is supposed to carry out the CO2 is being trapped. So look for these types of patients to have higher than normal levels of CO2. Also, on an X-ray, the lung size might actually appear larger since over time there is an accumulation of volume. So in general, patients who have an airway disease exhibited by a decrease of air flowing in and out of the lungs will be at risk of air trapping and increased levels of CO2. Now in the upcoming videos, we'll discuss strategies to identify and modify ventilator settings to treat patients with airway disease. Next is alveolar disease. By alveoli, we simply refer to the non-airway part of the lung. There are over 300 million alveoli in the lung, so if you can't see it in this drawing with the naked eye, it's because, well, you can't. They're microscopic. But let me show you a cartoon of what one little alveolus is, as well as its purpose. Here is one magnified alveolus. Again, notice that this is not an airway. This is where air terminates into. In other words, as air is inhaled through the airways, air eventually ends up going into the alveoli, which are tiny little air sacs. From the alveolus, the oxygen can diffuse into the pulmonary bloodstream, and this is where blood becomes richly oxygenated. But if the alveoli is damaged, it can collapse on itself. This leads to the inability to adequately inflate the lung, and if we can't get adequate volume in, then we'll have a difficult time getting oxygen to the patient's bloodstream and their body. So depending on the severity and extent of the alveolar damage, patients with this disease will have a difficult time getting adequate volume of air into the lungs, which in turn will lead to decreased oxygenation, and on an X-ray, the lung may actually appear smaller in size. In severe cases, alveolar lung disease can lead to ARDS, but we'll talk more about this later. For now, let's recap and do a quick side-by-side comparison of the two general categories of lung disease. In an airway disease, the speed of air flowing in and out is decreased. With alveolar disease, it's not an airway issue. It's a matter of collapsed alveoli not able to open to receive volume. Therefore, volume entering the lung will be decreased. In airway disease, the patient will have difficulty getting volume out, which in turn leads to air being trapped in the alveoli. In alveolar disease, the patient will have difficulty getting volume in due to collapsed alveoli. In airway disease, because the patient will have difficulty getting volume out, this will lead to increased PaCO2 levels, since CO2 is not being properly ventilated out. In alveolar disease, because the patient suffers from alveolar damage, this will lead to decreased PaO2 levels. In airway disease, because the patient is not ventilating CO2 out, this disease category is said to have a ventilation issue. But in alveolar disease, because oxygen cannot enter the collapsed alveoli, this disease category is said to have an oxygenation issue. On an X-ray, the airway disease patient usually has larger looking lungs because of air trapped over time. On the other side, the lung appears to shrink in size, so the chest X-ray will appear smaller. This side is referred to as the obstructive disease, while this side is referred to as the restrictive disease.
So I hope you like.
So in reality, usually we're going to be seeing more of the obstructive disease, specifically in the areas of anaphylaxis as well as asthma, but you can have alveolar disease and or alveolar misfunction, really, because in this video they're talking about chronic things like people with COPD. That's the chronic obstructive pulmonary disease, which basically is that chronic restrictive component that leads to that barrel chesting from that air trapping. But we can also have an alveolar um, issue if we have things like a collapsed lungs or different things like that. So we look at different aspects and realize that we're looking at a very small subgroup of respiratory conditions on the main point with ours. We're looking primarily at acute respiratory distress, but there is this large component of chronic respiratory distress that we're not going to look at as much. So let's go ahead and look now at what the mechanical ventilation does. And really, so this is the ventilator that would be doing breathing for them, but it's very similar to what we do with our positive pressure ventilations when we do either use a bag valve mask or our rescue breathing. And so look at it more from that standpoint opposed to the pure ventilation, even though knowing what the ventilator does is a good thing as well.
Some of the patients you will encounter may develop acute respiratory distress syndrome, also known as ARDS. In ARDS, the affected part of the lung is not the airways. Rather, the affected part of the lung is at the alveolar level. ARDS is caused by leaking of fluids into the tiny alveolar sacs of the lungs. So, for example, here is one magnified alveolus. And normally, oxygen that is inhaled into the alveolus is supposed to diffuse into the blood so that the blood can deliver the oxygen to the body. But in ARDS, fluids fill the air sac. The integrity of some of the alveoli will be compromised, often leading to alveolar collapse or atelectasis, and this will ultimately compromise gas exchange. So as a result of diffuse alveolar collapse, the lung will appear to shrink on a chest X-ray film. Collapsed alveoli may also result in refractory hypoxemia. Refractory hypoxemia is hypoxemia that does not correct with the administration of supplemental oxygen. In other words, you can try to administer high levels of FiO2, but because the alveolus is collapsed and compromised, oxygen concentration alone will not correct the hypoxemia. Correcting refractory hypoxemia will require a recruitment of the alveolus, which is a reopening or a restabilizing of the collapsed alveolus. The oxygenation status of the patient is also one of the ways in which we classify the severity of ARDS. So to determine the oxygenation status, the clinician should perform the PF ratio, which is simply the PaO2 divided by the FiO2 of the patient. Here you can see the classification of the severity of ARDS, as well as the mortality risk. So improving oxygenation will be one of the challenges in treating ARDS. But how can we get oxygen in if patients with ARDS have a difficult time getting volume into their lungs due to the fact that the alveoli are collapsed? Reopening collapsed alveoli will require an immense amount of patient effort. Additionally, the lung will tend to recoil upon inhalation. In other words, even if the patient does inhale volume, the lung will immediately want to recoil and exhale. This ultimately leads to shallow and rapid breathing. So that begs the question, what are some strategies in modifying our ventilator settings and treating patients with ARDS? And the answer to this question is coming up in the next lessons, so stay tuned.
So that gives us some basics on this more chronic component, but let's continue to look now then at the overall treatment of respiratory distress. Oh, I missed. This was the one that I was really talking about before. So let's watch this, I guess, beforehand. Sorry about that.
So what is a mechanical ventilator and why would we need to place a patient on it? A mechanical ventilator is a life support machine that breathes for the patient. It can assume all of the work of breathing or some of the work of the breathing. In other words, it can provide full or partial respiratory support. It is usually indicated for those patients who cannot breathe adequately. In fact, mechanical ventilation is indicated when a person cannot achieve an appropriate level of ventilation to maintain adequate gas exchange and acid-base balance, which is usually obtained from an arterial puncture. It is usually manifested in an arterial blood gas in one of two ways, or both. First, the patient may not adequately exhale and remove CO2 effectively. Now, the removal or exhalation of CO2 out of the body is called ventilation. A patient who is not ventilating properly exhibits increased levels of CO2 since they're not ventilating it out of the body. This patient is at risk of respiratory or ventilatory failure and is in need of mechanical ventilation. Or perhaps the patient might be ventilating adequately, but the oxygen that's breathed into the lungs may not effectively distribute to the body. You see, the adding of oxygen into the blood is called oxygenation. A patient who is not oxygenating properly exhibits decreased levels of PaO2 on the ABG. In this case, the lungs may need the support of a mechanical ventilator, but not because of poor ventilation, but because of poor oxygenation. So a mechanical ventilator can help the patient ventilate, get rid of excess CO2, and or oxygenate, get adequate oxygen. Now, unfortunately, breathing for a patient is more complicated than simply breathing for the patient. For example, in terms of duration, how long should an inhalation last? 0.5 seconds? 1 second? 2 seconds? Or how much volume should the patient receive? 100 milliliters? 1,000 milliliters? And how often should the patient receive the volume? 10 times per minute? 20 times per minute? And by the way, what oxygen concentration should you give the patient? Should you give 50% to the patient? 100%? And what about the mode of ventilation? Or how much pressure can the lung be inflated to? You see, answering all of these important questions and more are vital to successfully providing adequate mechanical ventilation. So we need to first understand the basic settings, and that's precisely what we will do together in this chapter.
So I hope you liked this video.
So again, not that we're going to be using mechanical ventilation, but we do similar things with our positive pressure ventilations using the bag valve masks or our resuscitation masks. But more importantly as well, I want to make sure you guys get a good overall sense of the depth and breadth of respiratory distress conditions, even though we're going mainly in this acute athletic sort of environment. So let's get back now to the specific signs and symptoms associated with respiratory distress. Now, I want you to take a good look at this list on your own and have a decent understanding of what these are, as well as what sort of things cause them. And really, that's a great example right here of the idea that I want you to learn these and remember these for the purposes of the test here. So that way you have a decent understanding of everything that's going on. But when we get into practice, what we're mainly looking at is we're going to do a quick assessment. Can we see whether or not there is any breathing going on? And then we're going to check for adequate breathing. And so we're going to listen with our stethoscope quickly on both sides for both lungs and see if we hear any of these abnormal breath sounds. Now, the abnormal breath sound is associated with different types of conditions, but really at our skill level at this point, without more advanced training, it doesn't really matter what type we're seeing, because we're going to treat all respiratory distress similarly based on their degree. So we don't really have a ton of different medications or different options that more advanced people might have, but we still need to have a good understanding of the basics of what these different abnormal breath sounds are, what they sound like, and then what conditions and treatments there are, simply from the standpoint of a comprehensive nature of our education. So this is a great example of something that you have to learn, look at now, but isn't going to make a big deal clinically, but you have to have the foundation of knowledge so that you can at least have the ability to know what you are then not practicing on. So you're going to bend the rules by not figuring out exactly which sound they are, but you need to know that you're bending the rules to begin with. So when we get here, if you remember when we were talking about breathing from the standpoint of a vital sign, we talked about rate, but also the rhythm and quality, this idea of quantitative and qualitative data for our vital signs. And so we have our rate, right, and our normal is between 12 and 24 breaths per minute, a little higher for pediatrics depending on the age and the situation. But we also need to know whether it's regular or irregular, and whether or not we see large amounts of effort being imposed, whether that's labored or normal breathing, inadequate or shallow breathing for their tidal volume, whether we see this equal or unequal chest expansion. And obviously the absence of breath sounds would mean that we're not getting any breaths. But we also have these abnormal breathing patterns that we'll look at as well. So you can see a lot of these signs and symptoms even before we assess this. So you can assess the abnormal breath sounds, but what we're going to usually be dealing with to begin with beforehand is we're going to see this altered mental status as the patient is getting decreased oxygenation to the brain, thereby making them feel dizzy, a little lightheaded, not quite all there, as their brain is struggling to function. The other telltale sign is this pale or blue skin, and it's cool and clammy with that. Other things that you might see as well, inability to speak in a full sentence because they're requiring more force for breathing, excessive coughing, or this tripod position that we saw, right, with pursed lips, nasal flaring. Those different conditions as well are all signs and symptoms that you would see of inadequate breathing, regardless of the breath sounds. And we're going to call all of this inadequate breathing respiratory distress. Now, this is obviously much more common in the general population. When we look at this idea of obstructive airway from COPD, right, medical illness, but we also can see it in some more acute situations: electrocution, shock, heart disease, heart attack, chest lung injury, allergic reactions, and poisonings. So respiratory distress is still something that we will possibly see. I mean, most of our cases will be something with a more exercise-induced asthma or maybe some sort of allergic reaction, but you can see all of these different components there. And so the other thing with this is the symptoms are subjective and may not reflect the extent of the condition. So this is where we're going to look at oxygenation levels and different components as well. So some possible causes of breathing difficulties in the athletic population. Again, just a list to take a look at as far as different components. But you can see, a lot of these are trauma related as far as the top part. If you have any trauma to the face, throat, or chest, you have the possibility of creating difficulty breathing. But we also have these medical conditions as well. Exercise-induced asthma, like I said, being the most of them. Hyperventilation can be as well, where this is just increased breathing that leads to decreased expiration of CO2, so a buildup of CO2, which causes that lightheadedness. If you like hyperventilating, you're not getting as much air out as you need, because the air in your lungs will have enough oxygen for a while, but you build up the CO2 and can't get it out. And then anaphylaxis as well. So other signs and symptoms of breathing difficulty, go over that again over a long period of time. That loss of muscle tone and flexibility of the wall, stiffness of the alveolar sacs. In pediatrics, we see proportionally large tongues and underdeveloped and flexible trachea and chest walls. The seesaw breathing pattern and nasal flaring is basically due to the high pressure that they're putting on themselves in order to get breathing. Creates this sort of pattern where they'll breathe fast and then they'll breathe slow, and you'll see that. Other signs and symptoms, going back to the same stuff again, just trying to hit it multiple different ways, from different signs that you would be seeing when you're going through these: flaring nostrils, right, tripod position, cool moist skin. This shortness of breath, right, is really the telltale sign. If you have this shortness of breath, the inability to speak in a full sentence, that will occur usually prior to all of these other sorts of things, right? And so usually we get them where somebody's at the shortness of breath, but if we can get later on, that shows that. Now, respiratory arrest is the complete failure of the respiratory system. These people are going to go unconscious very quickly, right? This can occur as respiratory distress gets worse, right? If we have something like an acute anaphylaxis, eventually the airways will get so obstructed that air will not able to get in or out, and brain damage occurs in 4 to 6 minutes. And so this is where the debate over airway and circulation comes into play. Circulatory conditions are much more common than respiratory conditions. As far as in the general population, heart attacks are more life-threatening on a regular basis than respiratory attacks. And so because of that, you've seen some of these primary assessments move to like CAB, which is circulation, then airway and breathing, partly because the hands-only compression will compress the chest as well and will give some breathing component with there. But we do know that either way, both of these are very serious conditions that need to be addressed rather quickly. So as far as emergency care, what we're going to do, like I said, you can see here we have emergency care for respiratory distress. It's all basically going to be the same component. We're going to initiate our emergency action plan, respiratory distress, right? Because of its prevalence to lead to respiratory arrest and the inadequate breathing to sustain life. We're going to go ahead and initiate our emergency action plan with people that have any airway compromisation. Right? We complete our primary assessment for whether or not we have airway, summon an advanced medical personnel if necessary. That's usually part of our emergency action plan. Place the athlete in a position of comfort, complete a sample history. And these two aspects, this position of comfort will help in breathing. We might also add into this aspect with assist athlete with prescribed medications in there as well, the delivery of supplemental oxygen. But the sample history that we've seen before helps us get an understanding of what might be causing the respiratory distress, and our focused exam will as well. And so it's a basic, basic care component with this as far as respiratory distress goes. You're going to look for whatever causes we can, but we're going to basically put them in a comfortable position administer any prescribed medications, and this will include the use of supplemental oxygen if warranted, and we'll look at that when we talk about supplemental oxygen. All right. And so you can assist athlete in trying to control breathing, pursed lips, single nostril. Basically what this will do will slow down breathing, allowing for deeper breaths, oftentimes in respiratory distress. The respiratory rate will increase to try to compensate for the lack of oxygen, or really the buildup of CO2 occurs before the lack of oxygen, and so they try to get more CO2 out by breathing faster. But unfortunately, as we saw before, if you have that obstruction and you're trying to blow out through a smaller tube, that takes more time. So if we can get them to focus on exhaling over a period of time, right, that's where you get those 2 times aspect, where you breathe in for 2 seconds, out for 4 seconds, as a stress management aspect. It helps remove the CO2 and decrease that stress in there. But perform the ongoing assessment. If they're unconscious, we're going to continuously reassess if they are unconscious, right? That's a medical emergency regardless, but respiratory distress also in there. And then breaths below 12 or above 24, immediate action as far as supplemental oxygenation or this positive pressure ventilation may be warranted if we're not getting adequate breathing. All right. So emergency care for respiratory arrest. This is no signs of breathing but has a pulse. So this is somebody that has a respiratory condition, right? Often what we will see with this is either choking or anaphylaxis, where we caught it early enough that there hasn't been heart involvement yet, but instead is so the heart's functioning at some level, but breathing is not. And so anytime we have no signs of breathing but have a pulse, that's respiratory arrest. And for care of that, we'll see here in a minute, but we can't confuse that with this agonal breathing. And we'll listen to this agonal breathing here a couple of times. But basically notice how this gasping noise, right, is associated with this agonal breathing and is not associated with real breathing, but this like fake breathing. So obviously this person is moving some air, but not enough to actually get air exchange. So that gasping or sounds is really a brainstem reflex that is the last respiratory pattern that occurs during these early stages of cardiac arrest, right? And so in reality, that can be confused for breathing because you hear, right, these sounds that are often associated with breathing, right? Because they're obviously moving air, a little bit of air, to make those sounds. But if you try to reproduce those sounds yourself, you realize you're really holding your breath and then just letting small amounts of air out in there. So agonal breathing is considered respiratory arrest. So let's look at some of these care for respiratory arrest as well. So these are individuals that we are not having adequate breathing occurring. Right? So they moved beyond respiratory distress, where they're breathing and they're maybe on the edge there. But these people are not breathing, either due to an obstruction or something else. And so what we're going to do in rescue breathing, and you can see as you follow down this, and this is in your textbook as well in case it's a little bit hard to see on the video here or in the PowerPoint, but you go through your basic primary care or primary assessment, and you see in this situation we have people that has no breathing but has a pulse, right? And that's the condition for respiratory arrest, right, and rescue breathing, and we reassess every 2 minutes for that. So a couple of things to also look at with this is normal breathing the air has about 21% oxygen in it, right? And then even when you expire and you breathe that air out, it still has 16 to 17% oxygen. That's why we can breathe out, use our breath breathing out, and get still good ventilation and good airflow into their lungs, and they can then get oxygenation as well. And then through the passive exhalation, as we blow in, we'll expand that, and as we stop blowing in, the air will come out as the lungs recoil, and so we can get good air exchange with that. We can also then add supplemental oxygen to the artificial ventilation, either through a lot of resuscitation masks, and when we look at oxygen supplementation in lab, you'll see that a lot of these have a little valve in them that allow you to add supplemental oxygen, or the bag valve mask has the added benefit of starting with 21% oxygen because it's not being breathed out, but you can also add supplemental oxygen to that as well. So as we wrap up things, right, breathing emergencies exist where there's any sort of function of the lungs or the airways, right? We primarily will be looking at, in an athletics environment, airway obstruction issues, primarily, like I said, asthma, anaphylaxis. But I wanted to give you a more range of chronic conditions as well that you might be looking at if you're working with a more general population. You got to look at all of these different techniques. And so when we go and we talk about the skills in lab, we'll talk about advanced airways and how we can go ahead and in those obstruction conditions add artificial airways that will hold those airways open, so that way while we're delivering breaths with an unconscious individual, right, with respiratory arrest, we can deliver better breaths than just our normal first aid component. But this is a good example of where athletic training and EMT sort of skills overlap very much. You heard in some of those videos them discuss the fact that EMTs and paramedics are often the first ones there. Well, athletic trainers are on site even before those individuals can get there. So if we can add some more of those skills to our techniques, they're not very difficult to do. All you really need to do is practice them fairly regularly so you can keep up with them, and you'll be able to make this care, and that initial care may make the difference between life and death. So in lab, we're going to look at suctioning, which is basically, in this situation, if there is an obstruction, it may be due to mucus, vomitus, or different aspects like that. And so we actually have to remove the obstruction, and you do that through suctioning. The oropharyngeal airway, nasopharyngeal airway, and supraglottal airway are different advanced airway techniques that you can use. The oropharyngeal airway obviously goes through the oropharynx. Nasopharyngeal airways goes through the nasal and into the nasopharynx. The supraglottal airway will actually be administered all the way down and hold the epiglottis open. And so these are the preferred ways as far as things, and there are multiple different supraglottal airways, some that are more easier than others. But when EMT is going to insert an airway, they're going to do a supraglottal airway. And the big thing with this is basically this is for anybody that is at significant risk of losing their airway. So either they're unconscious, which is about the only time I would ever do this. In fact, the oropharyngeal airway and supraglottal airway are not recommended for conscious individuals at all because of the gag reflex. The nasopharyngeal airway could be used with a conscious individual, and the only time that would be beneficial is if they have some sort of fracture to the face area, and so inserting that nasopharyngeal airway. But if they're able to breathe on their own, I would not take away their airway and add an artificial airway, even if they are unconscious. But if they are unconscious and we're struggling to maintain an airway, and we have to go into rescue breathing, we'll add an airway there. And then we need to understand how to use the bag valve mask, and then oxygen supplementation, how we can add oxygen to those situations. And then the pulse oximeter actually measures oxygenation of the blood. So we'll look at those in lab.